Thank you very much indeed for joining us for this afternoon's webinar from the ECDC Lighthouse. Today, the webinar is called Escaping the Algorithm, How to Make the Health Information Environment Work for Public Health. And we have three fantastic speakers, really top-notch people today who I will let Alexis introduce to you in a moment. I think this promises to be a really a fascinating discussion here. Lots of interesting things, all very, very topical. So thanks for joining and stay tuned for more. I wanted to introduce myself, John Kinsman. I'm the head of the Social and Behavioral Science group here at ECDC. And so the Lighthouse is our project here to provide an opportunity for colleagues across the EU to network and learn and so on. This is the sign up opportunity for you. So if you want to come and join us, there's your QR code. You can also go to the URL lighthouse.ecdc.europa.eu. We have lots of things going on. We have these webinars, we have follow-up events, we have e-learnings, which I'll tell you about in a moment, and online trainings and different group activities. So please join us. It would be fantastic if you're not already a member. And then I would like to show you a little bit about the e-learnings that we've got. If we could have the next slide. There we go. This is something which you can access through the platform. And if you go this year, you can see the page on the left side there, how it will look. I just want to raise your awareness about these now. Under learning, we've got these three e-learnings on role of social and behavioral sciences in the prevention of infectious diseases, behavioral and social science research methodologies, and also community engagement and socially vulnerable populations. So these are e-learnings that will take you about 45, maybe 50 minutes or so to go through and give you a good grounding in the topic. So if you're interested, please go there. They're really quite nice, I will say so myself, if I may. I hope you'll find them very beneficial. Now, if you are not yet a member, next slide, please. This is what you need to do. When you sign up, you're going to come to this page, and this is important if you want to join up. So you'll see there on the top left, my profile. Click there, and then you're going to get some things that you need to fill in order to join. So you've got your first name and your last name. That's pretty obvious. The country you're in, and also your nationality. And then over on the right, the affiliation. And there we need to tick on that little the little tick box there, and write in the institute or organization you work with. Please do this. It's really important. We need to have that information in order to verify you. So you might be in the Lighthouse, but feeling like you're not really in, and that's probably because you haven't yet filled in this information. So please make sure you do that, and then we'll be able to verify you and let you in, and then you can join the fun and have lots of other interesting things going on. So we got our three speakers here. And each of them is going to give us an overview of what they have to say, and then we're going to have our usual Q&As and chats and questions in the chat for you to contribute to and participate in. I'll leave it over now to Alexis, our expert moderator, and I wish you all a very nice webinar. Thank you.
Thank you very much, John. Welcome, everybody. We're so glad to have you here today for this webinar. And it's going to be a jam-packed schedule. So I hope that you can stay with us for the full time. Keep in mind that this is an hour and 20-minute webinar. So we'll continue until 20 minutes after the hour. So please make sure to stay with us if you can. I just want to go over a couple of housekeeping rules before we dive into the content for today. First, this webinar is being recorded, and it will be uploaded to the ECDC Learning platform and onto the Lighthouse platform. And then secondly, questions are absolutely encouraged. So please put your questions in the chat at any time. And if your question is directed towards a specific speaker, make sure to indicate that when you post it. And you can also give a thumbs up or a heart to questions that have already been put in the chat to indicate that you want them to be asked. And then that way we can prioritize the ones with the most likes and thumbs ups and hearts and things like that. Also, make sure to keep your mobile phone handy, because in a moment we're going to start with an audience engagement activity through a Slido poll or several Slido poll questions. And then lastly, I just want to go over the structure for today's webinar. We will have 3 speakers, as John mentioned. And so what we will do is first dive into some initial poll questions as like an icebreaker. So there will be 2 questions to answer. Then we'll have 2 speakers, first Tina, then Neville. Then we'll go back to the Slido and answer 3 more questions. And then we'll have our final speaker, Catherine. And then we'll have a moderated question and answer session to close us out. For the Slido questions, we'll be asking some technical questions, so this will be incorporated into our discussion, and the speakers might also be referring to some of the answers, so we definitely want to hear from you. So with that, let's go ahead and get started, and take out your mobile phone, or you can also join via the browser and start answering these Slido polls. The first one is actually just to get to know where you're from. So not a technical question, but more, where are you joining us from? We assume most folks are from Europe, but not necessarily, since this webinar is open to anyone in the world to join. So we're just curious. And I'll give you a couple of seconds to respond. It looks like, as expected, the majority of folks are from Europe, Western Europe primarily, but we're glad to have you here. And so let's go on to the next question, if that's all right. And this one is a word cloud. So now we're focusing on topics and getting into the content of today's webinar. We want to hear from you. Which health topics have you seen information about that seemed unreliable or misleading? And already I see those that have responded have put vaccines, which is no surprise at all. But in addition to vaccines, are there other topics that you have seen where you've seen information that was unreliable? So take a moment to add in a word or a couple of words so we can populate our word cloud. And we'll bring the answers back up later and to talk about them more, but we do appreciate you sharing your thoughts now. Very interesting. I already see, besides vaccines, cancer treatments, weight loss, nutrition, menopause. Yes, I have also seen a lot of misinformation on this. So a lot of food for thought here. Thank you so much. Okay, in the interest of time, feel free to continue to answer if you haven't already answered, but I'd like to go ahead and move on to our first speaker of the day, Dr. Tina Purnat. She's a Doctor of Public Health student and Pranya Leadership Fellow at Harvard T.H. Chan School of Public Health. She's also a former WHO lead in Infodemic Management, who now works at the intersection of public health, data, and technology. And she specializes in understanding how digital information environments affect health systems, people's relationship with health information, and public health practice. So with that, I will turn it over to you, Tina.
Thank you very much. You should see my screen, right? Hopefully.
Yes, we can.
I want to thank you, colleagues at ECDC, for the invitation to speak today. I was actually tasked to take next 8-9 minutes to offer a way of thinking much more broadly about the information environment as a system that asymmetrically concentrates harms, narratives, impacts. It's making it really hard to cultivate a common understanding of health information and promoting health and well-being. So we'll look at a practical map or a diagram that I put together for the information environment, and then discuss at a very high level what each of us can actually do about it, depending on the specific lever that we hold in the health system. So I put the link to my presentation in the chat, and also included some extra slides in the appendix for you. You can take a look after the webinar. Now, before we talk about the system, it's worth pausing on the sheer breadth and depth of the problem that we're facing. You saw this in the Slido poll as well. when you look, for example, at this list that I collected here, it's not just about topics discussing vaccinations. There's also nutrition, mental health, reproductive health, aging. What strikes me at this list in health misinformation research every time isn't just the length, but it's also that these topics occupy a very specific special place in our heart, in our lives, because they're deeply personal and they're linked to our values, our social status, even our sense of shame and social stigma connected to some of these. And because these topics are so tied to who we are, it also means it's much harder for a person to evaluate health information on scientific validity alone. But this also means there is a massive opportunity for us, because if we understand that health is social, we can then move beyond just delivering facts to people and convincing them in a way of seeing things. So, the question is no longer whether our communities are navigating a complex information environment. We know that we are, all of us, but we can, but then, we need to ask ourselves how we can help them navigate and ourselves navigate it without losing their trust. Our experience shows that we need to think about the complexity of all of this that I was just talking about as an environment. It's not just a matter of isolated pieces of misinformation or specific difficult topics in health. And to really get our heads around this, I want to focus on this definition from the Royal Society and the Oxford Internet Institute. And, this quote is really important because it changes, I think, how we see the challenge. One, it describes a dynamic system, and that means that the information environment isn't just a backdrop to information. It's actually an ecosystem where a change is one part. So, for example, if one part changes, like introducing a new AI tool, that change shifts also the balance of the whole. Then it also says that it includes agents and processes. And this is a reminder that the actors aren't just humans anymore. They're also the algorithms, the designed environment, the non-human systems that decide what actually reaches a person's screen. It spans also individuals, organizations, technologies. So that means we can't just look at a person's health choices without looking at the tech they use and the institutions that they are in relationship with. And then the most important part is the last phrase, engage with meaning. In health, we often act like we are in the fact business, but humans are in the meaning business. And they are trying to make sense of their lives, their fears, their families. So this definition forces us to admit that if we only fix the facts, but ignore the system, that shapes that meaning, then we will keep facing challenges in what we do. So I made this diagram to help visualize the health information environment as a series of nested layers, from purple individual all at the center to the broader structures in yellow that hold everything together. And you see here references to concepts from different disciplines, and it has a lot of detail. I put a slide with annotations into the presentation that I shared into the appendix, and feel free to explore that later. Now, most of us start thinking about the information environment with the orange parts, the content and the narrative landscape. And we usually think of this as the news or viral content, TikToks, videos, etc. But another example here is information voids, for example, in content dynamics. So that's, for example, silences that occur in the conversation when people have urgent questions. Is this new ingredient safe? Can I eat it? And the official sources haven't answered this yet. You can't find the information. And those moments are quickly filled by less reliable voices. Another example in this orange that I often discuss is discursive worlds. These are parallel knowledge communities, like those created by patients with rare diseases who develop their own standards of evidence and trust that can sit entirely outside formal medical systems. Then on the left in green is the communication infrastructure, and these are the pipes of the systems. But you know, the channels aren't just the digital channels in the way that digital marketing thinks about YouTube, Google, local radio. Think, for example, of the health encounter. It's an actually structural, unique communication channel in health context because it's built on a duty of care and personal trust that no algorithm can really replicate. And then we also have in green health information intermediaries and several other concepts that are also important, shaping the infrastructure beyond what we usually think. Then in lighter yellow, surrounding the green, orange, and purple is the core architecture, and that's the logic of the digital world, which is built to monetize attention of users rather than accuracy of information. We see this now quite a lot discussed also in media coverage. One key example here is, for example, engagement optimization. That's the way that the online platforms are designed to decide what you see first in your app or online when you're surfing online. And then it often amplifies sensational and alarming health claims because they get more likes and shares. Another feature here, I'm an informatician, so I speak about design a lot. For example, persuasive design features like infinite scroll in your favorite social media app. They're engineered to remove natural pause points and keep us consuming information longer than we intended. And then beyond that, in darker yellow is the outer ring of governance and policy. And these can be formal rules of the road, like regulations like EU AI Act or advertising standards in health, but it also can include public health governance tools. Public health professionals might know social listening, where we systematically monitor narratives to catch health rumors. And then in purple at the center, I haven't talked about it yet, but that's the person and community. And this is where cognitive factors like confirmation bias live. You might have heard of confirmation bias. It's our natural tendency to only believe information that already fits in our worldview. And in health context, this is really important. This is also where health, digital, media, science literacies are. There's also a newer concept called influence literacy, which is the ability to recognize when an online post or conversation is pulling on your sense of identity or belonging to make you choose a specific health treatment or lifestyle hack. And then on the right, last is in white, we have actors and agents that are cutting across every single level of this system. And you'll see it's quite long, but it's very specific and really important to consider all of these in the health context. There's a lot of packed into the slides because all of these actors have different relationship with health information and to others. They have also different incentives and standards of looking at health information, their properties and partnerships. Now, my second to last slide, I wanted to actually also talk a little bit about the purple that I marked here. So in addition to the concepts and structural components, we also need to think about what I think are four things that make this environment different from the way we used to think about information dynamics in how people search and understand health information. They are also the reason why traditional health communication approaches and public health tools don't always work in this new landscape. And we can discuss this in the discussion further, but just very quickly. First, the information environment is systemic, and that means you can't just look at one bad post or one misleading video in a vacuum because all of the actors and components interact with each other. Second, it's agent inclusive. It means that the environment is shaped not just by content, but by everyone and everything that produces, curates, and distributes information. Third, it's meaning centric. I mentioned this before already because focusing on the fact that information isn't just delivered is really important. So information isn't just a package; it's interpreted actively. And then fourth, it's dynamic, which reminds us that the ground is constantly shifting under our feet, and that might be frustrating, but the silver lining here is that because the system is dynamic and not static, it's actually responsive to the interventions and changes that we make. Now, for the last slide, again, this is very wordy, but I want to leave you with the core idea that the information environment challenges each of us differently. also the roles that we play, the types of professional roles and personal roles that we play. So our response has to be about playing to our specific spheres of influence, and we need to be deeply aware of those, and also at the same time identifying partners who can help us bridge the gaps and that we can't fill alone. So I sort of put different suggestions for what different actors and agents could do that might be different from how we have thought of things up until now. I won't go through all of them, maybe just to point out one per each. In the individual sphere, the yellow, we're fundamentally shifting the principle, for example, of health encounters from clinician having absolute authority to decide and communicate information to more of a patient navigation and shared decision making. Then in the middle one, for example, community and organizational action, we need to be thinking about to evolve the idea of settings-based health promotion. So we need to treat digital platforms and feed and online groups as actual health promotion settings with the same level of attention we give to schools or workplaces. Civil society is very important in the pink here as well. From the organizational point of view, also thinking about how we need to evolve our own public health structures and tools to adapt to this. And then from the purple point of view, also for public health organizations, the evolution is really important because we need to really just get better at rapidly understanding concerns and circulating narratives and the changing needs of the people that we serve, and then being more nimble addressing them. So we can definitely discuss this later, and I think we're going to see some examples of different actions that we can do. So really, at the end of the day, the information environment is something we all share. And every time we post, consult, or design a health information tool, we're either making that environment a little bit healthier or a little bit messier. So I hope that what I talked about helps you see exactly where you're standing, so you can start using your levers. And I look forward to hearing from the colleagues about their work, and also I'd love to hear your thoughts and get the conversation going. So thank you.
Thank you very much, Tina, for your presentation. And I learned so much. It was hard for me to keep up. Some things that really stuck out to me, of course, is humans are in the meaning business. I'm so glad that you reminded us of this. And I also really appreciated you unpacking the information environment and in all of its complexity in an easily understandable way, and highlighting the fact that it challenges us differently, which is, I think, something that's really important to keep in mind for this discussion today. So thank you very much, and can't wait for the discussion later. And for audience members, please do put your questions for Tina in the chat if you haven't already. So with that, I'm going to move on to our second speaker of the day, who is going to talk about experiences from his home country in Malta. This is Dr. Neville Kaleha, and he is a public health specialist and medical statistician who's led Malta's Directorate for Health Information and Statistics since 2007. He chairs the National Health Ethics Committee and co-leads a WHO collaborating center. With extensive experience in epidemiology, he played a key role in Malta's COVID-19 response and global health initiatives. So we look forward to your presentation. The floor is yours, Neville. Thank you.
Thank you. I just share my slides quickly. And whilst doing that, so thanks for the introduction. It always feels somewhat overwhelming and over-promising when you hear your own introduction. But anyway, I feel like I've been put here between two, juicy halves of a nice French macaroon, and I'm like the crappy bacon jam layer in the middle. But anyway, because I'm really not an expert in communication science as much as Tina and Katerina are. But I must admit, like most of you, I guess, I ended up kind of involved in this through my work. As was explained earlier, I work in health information. I guess, yes, That takes me to the second slide. And before moving to the second slide, though, I'd like to introduce you to this painting. It's a Renaissance painting. It's an Italian painting by Annibale Carracci, Allegory of Truth and Time. And it shows Father Time helping truth out of the well and treading over deceit as they move on, with showing truth to the world. But anyway, I thought it was nice to start with that. So yes, for those of you maybe from far who may have never heard of Malta and Gozo, yes, it does exist, and it's that tiny little dot on your map, which is not a misprint, it's actually a real country. And it's an EU country, pretty much on the southern border of the European Union. That's where I've been born, where I was born, and where I work. As my background, as was already introduced, I'm largely working in health statistics and epidemiology, both within the Ministry of Health and within the University of Malta. I'm also engaging typically at regional level, largely with both EU and WHO, especially in my area of health information, and also in this area of what used to be called infodemic management. But I don't want to dwell too much on that term because I guess we've evolved as well from there. Okay, just quick run through through my story, if I may say so. How did I end up in this? I was happily minding my own business, generating the usual health statistics up till January 2020, when obviously the world started turning upside down. And I'm sure, sorry, this is in Italian, but I'm sure some of you can handle this, and I guess you get the gist. We started getting some bad news, and the bad news, obviously, eventually, for all of us, hit home, okay? And eventually we got our first cases. What really scared a lot of people back here is this image here when it hit the news in mid-March 2020. And that's when things really started to heat up and anxiety seriously started to creep in. And this particular experience actually is what propelled me into public health communication and sort of managing this tsunami of information that people were being faced with. So this group showed up on Facebook, which is the social medium, I would say, which is the more popular one, I would say, in Malta, especially amongst young to middle-aged adults, even up to early retirees. And all of us thought, oh, wow, that's nice. Somebody actually took the initiative to set up an information page. And many of us actually started engaging, and it did actually start sharing good information, helpful information for the public. But then it started getting very weird. And the same page started advertising masks and sanitizer at obscene prices. And actually, when we started engaging with some of the more scary fringe items that were being shared on this page, we were actually being blocked. And then it came out, it transpired that it was actually an unscrupulous young man who was actually trying to obviously fleece people and take advantage of the situation. I think that's when we really realized that this is a war that is going to be fought in a different manner than maybe we are usually accustomed to. And in fact, then we sort of tried to set up a rival proper page within the Association of Public Health, thanks to some helpful journalists like the page I showed you earlier, like the slide I showed you earlier. We did sort of expose this individual, and that page kind of died a natural death. And I guess that is possible to some extent in a small country. So in that sense, we were lucky. So effectively, we realized that there was a massive vacuum out there. Alas, not even the international organizations actually had enough information on the subject in order to sort of appease the thirst that the population had. And, well, basically that information vacuum was filling up with anything that came along. So effectively, I must admit, I started sort of managing the infodemic before the term infodemic management was actually invented. Is this just Malta? Is this just in the past with COVID and whatnot? And I think you probably would agree. We have seen several of the, main promoters of certain misinformation and disinformation elsewhere also capitalizing on this fear, etc., to sell alternative products. And I think here we have a couple of examples. Those of you who are familiar with this space, I think, know these individuals very, very well. Did we try to engage with celebrities? I guess many of us have done, trying to engage with sort of people who are respected in society, popular TV characters, etc., etc. Admittedly, there are dangers in doing so, because these individuals ultimately are not scientifically trained, and they can ultimately damage, let's say, the product that you're trying to push. If they decide to switch sides and or else abuse of that trust to push other ideas. This is a presenter from a very popular show in Australia. Those of you who are familiar with the Today Show, I think his name is shown on the microphone as well. I'm not blaming anyone, but it is somebody who has, let's say, turned from pro to anti and damaging certain public health messaging recently. Working with influencers, this was something that was, like the first reflex reaction for many of my colleagues, at least, that we wanted to try and engage with influencers. We wanted to reach the youths out there who were obviously very keen to meet up, etc., and obviously might create environments where infection spread might actually happen more quickly. Working with influencers, in our experience, so I can't say this was everybody's experience, but in our experience, we never found influencers who are willing to do it out of their own goodwill. Okay, influencers ultimately are paid individuals, and nobody wanted to do it for free, frankly. So that was our experience. And we have seen, I think you might recall this situation where there was a shady organization that was paying several influencers to peddle certain information, and allegedly it was that had commercial interests in marketing its own brand of vaccines. Luckily, not all influencers, let's say, were without conscience, and some of these influencers actually exposed these funders. This is something that cropped up on my feed recently, and I mean, I'm not pointing fingers one way or another, but I'm just saying that it reminded me very clearly that ultimately influencers have a job. They are marketers, okay? And they need to be paid for their work. Another reality, let's say, is this one that I came across literally a day ago. And this literally popped up in my feed as I was preparing my slides. I don't know this lady, but it was a video that came up from this Microbe TV, which I understand is an initiative by a virologist in the US and has been running for several years. And this lady was explaining sort of her experience of transiting from strongly anti-vax to a pro-vax position. And I like particularly this quote that she shared, because I think it encapsulates nicely what we are facing, especially in vaccine hesitancy these days, that we have this third reality of individuals who have not experienced disease, but are fearful of the side effects of the vaccines to prevent those diseases. So they're sort of imagining a situation where you could prevent both, what she calls a third reality, which I thought was a very interesting way of looking at things. Again, a lot has been happening in the recent past. We've seen these outbreaks. The recent one in the UK obviously is very scary. Prior to that, I think if we refer to the measles outbreak in the US, the CDC actually has been reporting higher uptake now of the MMR vaccine, at least in New Mexico, comparing 2025 to 2024. And similarly, we are seeing long queues of people in the UK at the moment trying to seek the meningitis B vaccine. So all this is redefining, let's say, the reality we're working in. And ultimately, I know we're all scared, we all of us see social media, all of us see the kind of drivel that seems to be flowing in social media, but is it really an accurate reflection of people's beliefs? And this is, again, another survey I came across very, very recently from the Annenberg Public Policy Center in Pennsylvania. And despite all that we might think about even countries under a far-right government, ultimately, still people, believe their primary care provider most. And this echoes very much with our experience as well. And this has been the case throughout COVID and up till this very day. And this is, in fact, what we're trying to invest in. Okay, we have seen over the last seasons, over the last winter seasons, that influenza vaccination has relatively maintained its popularity, but COVID vaccination clearly has been coming down consistently. Also, there was research recently amongst doctors whereby a lot of healthcare workers expressed hesitancy in actually continuing to have boosters. So this led to an exercise by the Ministry of Health. I know I'm close to the end of my slot, but the idea is to develop. We're working with some very valid providers to look at this gap analysis from the Ministry of Health point of view. And the idea is to develop a curriculum and toolkit that could be first delivered to a group of trainers which trainers, local trainers actually, could actually take it into the future. Not only that, of course, but we also need to create a community of practice amongst them for them to be able to maintain their expertise. So this is what we're working on over the next few months, and we hope to make it in time also for the next seasonal vaccine season, next autumn and winter. So as you can see, we're hoping that by month 7 to 12, which would correspond with next autumn, we would have this. We might see some effect on the next run. So, and this brings me to the end. Sorry, I overran by a minute. Okay, I've been playing with Grok, admittedly, here to create this, but I think I don't need to explain what I've been trying to communicate here. And should you wish to liaise or communicate later on, those are my contact details. So I hope this was useful.
Thank you very much, Neville. And it absolutely was useful. We're so glad that you were the glue between the two pieces of the macaron, as you said, because we need that to be a perfect macaron. So thank you. And it was really helpful to, I heard a lot of examples from your experience in Malta that echoed what Tina was talking about in a more general sense, especially the vacuum of information. Tina talked about if there's no accurate evidence or information that can be provided by the health authorities, it's automatically filled with misinformation. And you saw that happening in real time during the pandemic. And what you talked about in terms of influencers and having a job, and we can't expect them to do work for free, was very interesting and a little unexpected, but helpful. And can't wait to see the toolkit and curriculum for trainers when it comes out. So with that, before we go to our third and final presenter, I would like to turn it back over to our participants. If you could get your mobile phone back out, and we're going to do another Slido poll. Keep in mind, this is a different code from the first set of questions, so you'll need to rejoin with the new code, and that's on the screen, or you can use the QR code and scan that. And so we're going to ask 3 more questions. And the first one is, how frequently do you search for health information online when consulting a healthcare professional? I know I definitely have a habit of doing this, but I can't be the only one. So I'll be curious to hear from you all in terms of, do you always search for health information when you're going to a healthcare professional, or less often? From initial responses, it looks like always, actually always and often are the case for most of our participants. Not so surprising, but there are some rarelies, so we might want to talk to you. Why not? So take a few more moments to fill that out, and then we'll move on to our next question, the fourth question. So when you search for health information or advice, where do you usually look? And you can select multiple answers for this one. So when you're looking for health information, is it your healthcare professional, doctor or nurse? Is it public health websites, AI tools or chatbots? So are you asking ChatGPT or Siri? Or are you asking friends and family? Are you talking to your local pharmacist maybe? Yeah, who are you consulting? We want to know. Okay, I see we've got about almost half of our participants have responded to this question. We have one more question to go. So, question 5, when you come across information you aren't sure about, what do you usually do? And this, again, you can select more than one answer. So pick the ones that, for the most part, apply to you. So do you look for more information online and compare different sources? This takes a lot of work, but might be worth it. Do you just check one website usually? Do you go straight to your healthcare professional? Do you share it with friends and family and ask their opinion? Or do you just save it, review it later? Take a moment. It looks like, take a moment to provide your answers. Looks like most people look for information online and compare from different sources. So no surprise here, we've got a lot of public health professionals who are doing their research. So that's good to know. Okay, well, you can continue to provide your answers to this final question if you haven't answered it yet. But in the interest of time, we will move on to our third and final presentation on health misinformation, a collective challenge and a major issue for women's health. So we're joined with Catherine Bertrand-Ferrandis. Dr. Bertrand-Ferrandis is a public health communicator and infodemic management expert. She's the former head of communications at the World Organization for Animal Health, with over 15 years of experience in risk and strategic communication. So the floor is yours, Catherine. Please go ahead.
Thank you. Can you see my screen? Yes, you can now, I think. I cannot hear you, but I think it's yes. Okay, yes. Thank you for giving me the floor. And so after the French macaroon, you will have a French accent right now. Thank you, Neville, for introducing my country food in your presentation. I'm here to speak about work that we have done last year about health misinformation, and more specifically, women's health misinformation here in France. So as you heard, I'm a veterinarian by training, and I've been working a lot with international organizations over the years. But for last year, I was working with a civil society organization called, can you see my slides moving? Yeah. called Femmes de Santé, so Women from Health Collective. Here in France, we are nearly 3,000 women members, women and a little bit of men too. They are accepted in our collective, and we are mobilized to really work on advancing women's leadership and health and environmental health here in France. It's really working by mobilizing collective intelligence to transform healthcare. And we decided, as I'm part of their strategic ethics and scientific committee, we decided last year to try a new format with an annual working group. And so as my expertise was on health information and communication, I proposed to share my knowledge with them, what I had learned around the world. And so it's how we started working on what will become a white paper on health misinformation as a collective challenge and a major issue for women's health. So this is the cover that you can see on the left. It was done so on an 11-month timeline with hearings from experts with rapid review of literature, international literatures. It's more than 1,600 hours of work. And it's what I will present to you today. I just want to highlight that this is a fully pro bono work. So we worked on this along the year, throughout the years with 16 other women. And I want to thank them here again because it was lots of hours and work done. And so they followed me in this crazy story, and it's really nice. So let's speak about what we found. First, why did we work on this? I'm sure you know it, but health information is really a challenge today. And you heard about Tina and Neville on the challenges that we are facing with the health information environment. But here in Europe, I don't know if you saw this number, but it's important to see that 43% of misinformation that is circulating on the social media in Europe is actually on the topic of health. So it's above politics, above war. These numbers are from 2025. Maybe it has changed the last weeks, but it's still huge, and it really highlights that health it's a real information, a real topic of misinformation. We had the feeling that women were vulnerable to this, particularly exposed to this, but we wanted to put some numbers and some facts on this. We know and we knew that there is real consequences in the world on health, and we wanted to see what was different for women. So you will see on my screen that you have a little planet when it's global numbers. You can see here with a specific disease burden, a little planet. And when it's France data, it's normally it should be a little flag, but it's FR. So why does it matter for women? We found that 56% of disease burden from health problems manifests differently and more frequently in women. So it's World Economic Forum number. Also 25% of women spend 25% of their life in poorer health than men, despite their longer lifespans. And French number now, and French data now, only 2 women on 10 think that they are fully informed about their health, their own health, all through their life. Sorry. So this is a barometer from France. So you can see that we have specific disease burden, health gap, and information deficit. how did we work? We started by analyzing the information environments. Again, my co-authors, they are from the health sector, all of them, from the private and public health sector, but they were not very informed about this topic, so they needed to have some additional training on this. So we started by analyzing the information environments, then focusing on the specificities of women's health misinformation, observing tension on how can we inform women on their health. So it was important for us to really try to see why we have difficulties to inform women on their health, and finally trying to propose some recommendations. So what are the specificities of women's relationship with health information? We found that first, the women, they still have a very pivotal, very CEO kind of role for health at home. And this is a French number. Sorry, it's not showing the little planets and flags, but 67% of women are still the primary parents handling all children's medical tasks in France, and it's even higher when you are talking about more advanced or more higher professional and social categories of the population. It's 82%. Also, we found that they are actively searching for information, for health information for all the family. And also they have increased specific information needs for their own women's health. We observed a lack of research on women's health. You, I think, all know here that unfortunately the health research for specifically women's health has been underfunding for years. It's getting better, but we are not there yet. There is a lack of investment. It's a World Economic Forum number 2, with 6% only of the private investments that is done in health that is dedicated to women. And in France specifically, we have only just 2 out of 10 women, but still fully informed. So it's the number I showed you right before, expressed differently. And we also observe some major barriers in medical communication. We see that there in France too, there is only 1 on 3 women that finds, 1 on 3 women have difficulties to discuss about their health with their health professionals. So it's only 2 of 3 women that feel comfortable to discuss about their health. It's still 1/3 that have difficulties. Bias, taboos are still very present even here. And we saw also crazy number is that 1 on 2 women report that they have experienced gender-biased treatments during their healthcare journey here in France. So they are uniquely vulnerable to health information, and as my colleagues expressed it very well before, so I won't go back on this. As you know, when you lack information, when you have questions that are unanswered, the misinformation is easily filling in the space. Just this in the white paper that I will share at the end, if it's not already done in the chat, you have a specific barometer that has been done for our white paper, representative of France, in collaboration with the CSA, that is a huge poll organization here in France. And we found that nearly 3 out of 5 French women think that they have already made a decision about their health based on false information or misleading information. And we saw here that it's small, sorry, on the slide, but if you read here on the right, you will see that the sources of this misinformation, of this false information is first internet or the AI, but second, it's coming from health professionals or institutions. So it's, at least they feel that it's coming from them. Tensions, as I told you, we worked about tensions, and we saw that healthcare system is has limited data about women's health, and health professionals have limited training. So there is a gap here. Also, the digital landscape and literacy challenges that I started to express and that you heard about in the previous presentations. And lastly, the commercial interest and wellness industry, with a booming industry on women's health, and it comes with, unfortunately, really bad use of data and the use of information, and showing the information as if it was scientific, but it's not. So recommendations are part also of the white paper, and to be very quick on this because I see Alexis, so I think I'm over time. So we have created systemic recommendations such as do tank observatory dedicated to identifying questions and information voices of women so that we can quickly answer to them. Also supporting people that are working on reliable information. And the last thing I will say, Alexi, is that these recommendations are not only on systemic level, they are also split up by a group of health stakeholders, because our point is that we can't only ask the state to change things, or the government to change things. We, each of us at each of our level, and with what we can influence in what we are doing or in our life, we need to really act to make sure that we fight against misinformation. So we called for a collective action urgently needed, working all together to build a more reliable and equitable and empowering health information environment for women. And you can find the white paper on this link and this QR code. Sorry if I use my last position in the game for being a little bit over time.
Thank you, Catherine. Really appreciate it. And no worries, I wasn't trying to rush you. I just see that we have...
I rushed.
But thank you so much for providing the white paper, because this, I think, I can already tell from all of the engagement in the chat that there's a lot of interest in the topics you discussed in your presentation. I know that I was really shocked by some of the numbers that you gave in your presentation. 80% of women in France are not fully informed. 3 out of 5 made a decision on false information, and they've seen the consequences. Yeah, these are pretty shocking, but it doesn't surprise me at the same time that women are still playing really a CEO role for health at home, and that means that they're going through having to, filter through a lot of information, and so that means sometimes they can come across misinformation without realizing it. So, and I liked how you ended on the fact that each of us have a role to play, because they're really a call to action for us to do more to fight misinformation and disinformation. So thank you for that. We have a little time left for our Q&A, but don't fret, everyone. I will talk more about this later, but we have a follow-up event next week where we'll be able to spend more time discussing with our experts. So that we will continue the conversation even if we run out of time today. I first wanted to bring back up our Slido poll results, because I thought it would be interesting to comment, to hear the thoughts from our speakers on the information shared by our participants. I don't know if it's possible to show the answers. But for the first one, with the word cloud in the health topics, that seemed unreliable or misleading. Maybe that's not something we can show. I'm just gonna check with my colleagues working behind the scenes.
We have it, Alexis.
Yes, thank you very much. Okay, so for our presenters, as we said at the onset, vaccines, for example, the biggest one in vaccination, not that surprising, especially given all the misinformation that Neville shared. Are there any ones on here that you find surprising or would like to comment on? It's okay if not. My thought was, is there anything that there can't be misinformation on, honestly, because it's covering a wide array of topics. Tina, please go ahead.
If I may, just to slightly pivot this, I mentioned in my talk that health is such a personal, it's linked to our identities, personal value, our worth in society, our worth in relation to our partner, our family, our community, etc. Any topic related to health and decisions we need to make about our health and well-being will raise questions. People are going to have concerns. They're going to need to weigh options. They're going to be looking at how others in their community are making decisions about the same idea. So to me, when I look at these, if you work in health, you are always going to be faced with having to address questions and concerns. And that also means perhaps misunderstandings, questions that might be coming from a person that has searched online and might have had and referred to unreliable health information, etc. So to me, it's not this is not a feast for me to snack on. Wow, there's so much of misinformation and the topics online. To me, I always ask, well, what's behind it? What drives this? And for each of these topics, whether it's related to deciding about cancer treatment and different options, or whether it's about supplementation, personal hacking of your health, whether it's something that you think through and feel over time, like menopause, women's health. These are all things that have different contexts, different needs, and people also seek services and information in very different ways contextually, depending on what the needs are. So as a public health professional, this is how I think, not necessarily about the topic, because health will always raise questions, concerns, and also will give an opportunity for misinformation to enter and rumors to enter the conversation.
Thanks, Tina. Very well put, and thank you for your input. And Neville, I see you're busy typing away in the chat, but you're also welcome to comment here as well if you like.
Sure. So I think the point I was trying to make, so what I feel is also in reply to the question you made earlier. So as long as people would like to know something, the risk of misinformation remains there, as simple as that. So as long as there's thirst for information, the risk for misinformation remains there. But that thirst might only be natural, like people facing, very new situations, young moms, teenagers facing puberty, etc. But we also are seeing new needs being defined. And I guess this is not new either, because we have been facing, huge marketing campaigns for more than a century now. But the case I mentioned in the chat actually was a frank chat I was having with my wife this morning. She's a practicing obstetrician, and she was telling me how one of her patients, they were having some chit chat, and she was telling her about her daughter, barely 19. She needs to get a job, to be able to buy clothes and stuff, and maybe, if she wants to, she can have also some lip filler. Like lip filler is actually a need for several young people nowadays, several young females. So we do get these artificial needs, of course, that have always been there and will always remain.
Thanks, Neville. Yeah, absolutely. Very true. Then on one of the next questions, which was on when you search for health information or advice, where do you usually look? Just taking a look at this one, I think it's not surprising that most people in the audience, they get advice from a healthcare professional and public health websites, which is great. But we also know that a lot of people are getting information from other sources. So, but this may go back to what you were talking about, Tina, in terms of who is an influencer. But was there anything surprising there in terms of the results that we got? Catherine, yes, I see your hand raised. speakers don't need to raise hands. You can just go ahead and speak freely.
Yeah, I'm always a little bit surprised by the fact that when you ask people where do you go when you need health information, they most of the time, majority of them, and it's the same for French people, French population or French women, they say we are going to ask to a health professional. In reality, most of us, we know that we start by typing on Dr. Google or Dr. ChatGPT. I'm wondering if we will find a way to really analyze this behavior one day. Maybe I'm in a bias and I think this, but it's not the reality, but I'm a little bit surprised. And also, I just wanted to say what I did not have the time to highlight in the study we made, the barometer, the purple slide I had in my presentation. We saw that young women from 18 to 24 years old, they give the same trust to people with academic degree, to people with an experience of the disease, for example, and to people that have already helped them. So it's really equal. And when you look at the French population, it's kind of the same data. So we really have, I don't know if it's a real shift in the French population. Maybe it was the same before, but we did not know it. But at least what we saw for last year women data in France, we can see really a generational gap between young women and women older, over 30 years old.
Yes, okay. No, that's good to know. Well, I was wondering that about this question because I was thinking, I was surprised to see not many people checked friends and family. And I was thinking, well, I might go ask my mom, you know, in a lot of cases, that might be the first person that I go to. But maybe that's just me. But thank you, Catherine, for that. Let's go to our very active chat. I will try to sift through all of these questions, and I see that some questions have already been answered. There was one in particular that I wanted to make sure and ask because I thought it was especially thought-provoking. So apologies as I try and get through to that one. It was from, yeah, Micah. I think I saw in here. I can find Micah's question. Okay. Then we have, okay, yes. There was a question from Isabella Balai that said, well, a comment, she created WhatsApp groups for physicians in Brazil. And physicians often know very little about vaccines and are frequently easy targets for misinformation. So this is getting at a question that I was actually going to ask about healthcare workers and the problem around misinformation with healthcare workers. How do we, can some of you, one of the speakers, talk about strategies that you've seen or you've used yourselves specifically when it comes to healthcare workers? Tina, no need to raise your hand. You can just go ahead and speak freely.
Yeah, it's easier because I know that both Neville and Catherine have also a lot to say. Just to make a point here, we often think about health workers as delivering services and serving patients and serving communities or community members. And the reality is that they are doing those things. This is their job, and they need tools, support, skills in order to be able to connect with their clients and to address their questions, know where to look. We also need to give them tools that they can refer people to a patient support group or to additional information or something like that. But we also need to think about health workers as they're human themselves. And if they do not have confidence in the products, the services, the health system that they are part of, then that makes it really difficult for them to do their job. And we need to address their working environment, the tools that they have, the type of support they have, and also the questions and concerns they might have about products and services that they are offering. And this is, as a public health professional, I think a lot about how we make our systems serve our workforce, not only our clients, because humans are parts of are basically what make our health systems work. And over to Neville and Catherine.
Sure. So thanks, Tina. In fact, if I can actually build on what Tina has just said, we do observe that our healthcare workers, due to the nature of their work, might actually be more exposed to, let's talk about vaccine side effects, for example. I mean, they don't see the thousands of people who got the vaccine and just walked out and did their shopping. They see those who might have had a reaction or came with a fever or with some symptoms or another. So they are at risk actually of having a somewhat, biased or skewed view of the prevalence of certain problems and complications. So that's one issue. And again, our experience has been, I'm not sure about you guys, but I come from a public health organization with a very small budget, okay? So we always try to generate champagne with a beer budget, okay? Sorry for the French reference, Catherine, I can't help it.
I love it.
The most effective, actually, intervention we found was investing as much as we can in family doctors, because we knew that family doctors were the ones whom people tend to turn to, but unfortunately they were also the ones who were most distant from our CPD efforts and our outreaches. So we tried to focus our efforts actually on finding groups and fora where we could actually reach out to the family doctors. And we have seen evidence that it has worked, because people ultimately, when faced with a problem, they will look towards a person of trust. And something else, by the way, at least in my culture, even the cleaner who works in hospital has some healthcare knowledge amongst some sub-cohorts of the population. And I'm not sure if you experience this as well. So there's danger there as well. I mean, there's a role also for reaching out even to these people.
Thank you, both Tina and Neville. And then Catherine, I know you want to add to that, so please go ahead.
Yeah, thank you. Just quickly talking about the fact that health professionals, they are also humans, and we need to help them to deliver or to face the challenges. And for that, I think that I talked about, for example, specific health technical aspects or topics, training them on this, on women's health in particular, but also training them on communication, training them on how to face somebody who will come with a diagnostic made on AI, for example, or training them to react to that is something that we do not do yet. We should probably focus on so that they feel more comfortable to navigate those situations that are challenging for them. So communication, and also, I don't know if it was said exactly, but helping them through detecting what is circulating in terms of questions and misinformation, for example. Sometimes disinformation is super precise, super picky with one specific data, and they don't know what to answer. And so the vacuum of answer is creating more distrust. And so giving them some types of easy to use answer, so that with a real network between professionals, helping them to have some insights on how to face this disinformation or this one could really help them, I think, to face the challenges. That's what I wanted to add. I see Tina knocking, so
We have so many more questions, and just one more minute left before we have to start wrapping up. But Tina, please, I don't want to lose the momentum on this. Please share what you have to add.
To add to this, +1 to what Neville and Catherine said, there is data from OECD that includes European Union countries that also looks at patient experience, so the length of the visit that they have with the healthcare provider that allows them to address their concerns and questions is related. It's correlated with better health outcomes. Take a look in my LinkedIn feed specifically. I discussed this recently, but there are structural things that we need to do in order to support the healthcare professional, that they have the time and the tools and the skills to be able to address this. It's not just on the skill side. It's not just on the systemic side. We need to be able to think of it as a package.
Love that, Tina. Thank you. Time, tools, and skills for the healthcare workforce. As an advocate for the healthcare workforce, since I'm working in health management, I am so glad that you shared that, and I think it's something really important to highlight when talking about misinformation. So I'm glad that it came up in the chat and in the discussion. Lots of other things came up in the chat that we weren't able to get to, and but as I said before, we have an opportunity to continue the conversation. And so if you're in the European Union or the European region, I should say, you are welcome to sign up for our Lighthouse platform. And then you can join us for a members only session on the 25th of March at 3 p.m. Brussels time, where our 3 speakers will come back and we will have a more informal kind of fireside chat where we will tackle the remaining questions, as many of them as we can, from today's webinar, and hear from them a little bit more deep diving into certain aspects of the topic. So I do invite you to join us for that if you're able to. I'm sorry that if you're outside of the European region, you can't join the Lighthouse. It's only for this geographic region, but we will, but we wish you could join that. Okay, so with that, I also want to say, as this is an ECDC webinar, you know we love data and we want and continuous feedback. So we kindly ask you, before you log off and before I turn it over to John for closing remarks, to please take a couple minutes and fill out our feedback survey. It's very fast, but it really helps us to make sure that we're providing content and events that matter most to you. And so we would really appreciate it if you could fill this out. Just scan the QR code, and I think there's a link in the chat, and we would be so grateful. And with that, I will say thank you to our speakers, and thank you so much, participants, and I'll hand it over to John, who would like to say some closing remarks. Over to you, John.
Thank you, Alexis, and thank you so much to Catherine, Tina, and Neville for a really, really, really wonderful set of presentations and an incredibly rich discussion. And also, I have to say, I've got 2 screens here. You were over here, and on the other screen, I'm watching ding, ding, ding as all the comments come in. Fantastic participation from everybody. I think this has been one of the richest chats that we've had in all of our webinars so far. This is number 12, and I think collectively you've broken the record here. So well done to all the participants. And as Alexis said, we're going to have this follow up next week. And I understand that someone put in the chat, oh, I can't make it because I'm outside the EU, and I'm so sorry about that. But it is for members only, and the Lighthouse is sadly an EU only organization. So please, if you're within the EU and if you would like to join the chat next week for a more informal discussion about all of these things, please join up with the Lighthouse if you haven't already and sign up. And I think that Petra has put the link for the follow-up event in the chat next week. Now, as Alexis said, we have another webinar coming up in just over a month. This one's going to be another cracker. This one's going to be about vaccination communication and how we can help. And in fact, this is something that's been coming here in the chat about the discussion about health workers, how health workers can be supported in their discussions with patients and parents and clients about vaccination and dealing with misinformation there. So I think that one promises to be really, really interesting too. And we've got 3 excellent speakers coming up for that one too. So please sign up for that one when you get the invitation. And in the meantime, thank you for joining us. Have a lovely afternoon wherever you are in the world. And I see that we have had people from all over the world, which is pretty fantastic. Thanks for being with us. Join us again next time. And once again, thanks to our fantastic speakers for a beautiful afternoon. Bye-bye, everybody. Take care.